And then phase 3 is always medication versus placebo, and it's double-blind. The site investigator doesn't know, the subject doesn't know what they're getting. And these things take time. So for pulmonary fibrosis, oftentimes they'll do at least a 1-year study with each of these phases, and in between, as they do phase 2, and it's taking a year, they're planning for phase 3, but they don't have the data yet from phase 2. So there's another year to sort of collect thoughts, get data, get everything ready for phase 3. Then you do phase 3, and if you have promising results, then you have to take the evidence to the FDA. The FDA considers the evidence and determines if the medicine meets the requirements for approval. So this process, this is just how it is with every medicine, but it's not a, oh, we found this medicine, we think it'll work for pulmonary fibrosis, and then 2 years later, it's out and ready to go. It takes many, many years, oftentimes 10 years, to carry these stories to completion, which can be really frustrating to think of when they're promising therapies, how long it takes. But there is good reason. You don't want a market flooded with medications that are faulty. And I've certainly seen medicines that went through this process, not with pulmonary fibrosis because there hasn't been anything approved, but with other conditions where they did this whole process, it got approved, the evidence seemed good, and then the post-marketing surveillance really blew up and said, hey, this medicine should never have been out there in the first place, and it's yanked from the market. Everyone's heard those stories. So Pirfenidone, how many people have heard of Pirfenidone? So a few people, but anyone who's been diagnosed with pulmonary fibrosis should find this story interesting. And it's right in the middle of the story right now. So the first thing is, this is a medicine that's approved in Europe, Australia, Canada, and Japan, but not the United States, and how can that be? So let me address this question first. That first one, why is it approved elsewhere, not here? Here's the story with it. The company that makes it, they came out with 2 identical studies. One was called Capacity 1, one was called Capacity 2. And both studies entered the same number of patients, and they both had an identical clinical design, where they had half the people on the medicine, half the people on placebo. They had the same outcome, and they had the same criteria for who could get into the study and who wouldn't. And then they followed it through, and at the end they crunched the numbers. And the way that it works in research is you're not just looking for good data, you're looking for a very scientific value when you say the findings that we have are not due to chance alone. That's the key with clinical research, where you say the difference between these 2 groups, the medicine and the placebo, is not just due to chance. We've really got something here. So one of the 2 studies did just that. It showed that it wasn't due to chance alone. The other one was close, but it didn't quite get there. When they combined the data, which they did because both studies were identical, then it was in support of the medicine. So in other countries, they accepted the combined data and they approved the medicine. The FDA has a policy that goes back a long time that if there are 2 clinical studies that are identical in nature that have differing results, there has to be a tiebreaker to say which was right, to have more evidence, that it's up to the company to do more. So the company did just that. They decided to do a tiebreaker, which I'm really glad that they did. And that's where we are right now. So it should be finished in about February 2014. That'll be the last step. The first 2 were both phase 3 studies, so near the end before getting it through. But this last one will be out in February 2014. They'll probably take the results to the FDA by summer of next year, and we'll know something about approval, I would think, by the fall or so. But I don't have the inside track on that. But it takes a long time to get these processes going. So this medicine, Pirfenidone, it has some promise, but the second thing is important. Because once you hear there's something that may be coming out there soon, the assumption that I think everyone has is a medication is going to be approved that will improve lung function of those who take it. And I have to be clear with this, that's not the point of this medicine. The point of this medicine, think about that fibroblastic foci, is to stop it from getting worse, from causing more fibrosis over time. So what they're looking for in the study is that people with idiopathic pulmonary fibrosis on the placebo group, that their breathing tests, their pulmonary function tests, get worse over time. But that the people in the Pirfenidone group taking the medicine are stable over time, not getting better, but not getting worse. That's what they're looking for. So that's the hope with this medicine. The story's still not out, but there is a story that's ongoing that will be out soon. So what about mucomist or N-acetylcysteine or NAC? It's all the same thing. A lot of people with pulmonary fibrosis, it's recommended to them that they take it. And what I'll tell you about it is that it does have some rationale. NAC, this is sort of a antioxidant that's very in vogue with a lot of different conditions for a good reason. We found that it protects the kidneys from contrast damage from CT scans with contrast, that it reverses Tylenol overdose. Has made a tremendous difference to me in the ICU taking care of people who've overdosed on Tylenol. Can protect the liver in people who go into liver failure. So not surprisingly, it gets looked at in a variety of different ways. There's some evidence that it may help. It's not definitive. The studies were not the best in people with pulmonary fibrosis. But the studies were done in Europe, and they used a pill. And that pill is not commercially available in the United States. It's a long, drawn-out story of why it's not. So there are two options. The prescription that a doctor can do in the United States is this like really terrible slurry syrup that tastes like rotten eggs. I mean, it just does. And you know, 2 or 3 times a day, and boy, so no one does that. But you can get the NAC through like a GNC store. The only potential problem is you don't have FDA regulation, so you don't know 100% if you're getting the right medication through the GNC store. What is clear is that it should not be used in combination with prednisone and Imuran. In other words, probably prednisone and Imuran should not be used for treatment of pulmonary fibrosis. Can we wait a minute, or?
With the hospital in Northern Virginia, we decided to take it through a nebulizer, which actually, and in a saline concoction.
The tough, when it's used in a nebulized form, it's usually mucomist is what it's called for whatever reason. The tough thing about mucomist is that it causes bronchoconstriction, so you have to do an albuterol pre-treatment. Most people do. Maybe you're okay. Well then, that's very good. But most people, it becomes a regimen of albuterol and then the mucomist, and that's probably the one thing that's known about it, is that it's not harmful and that it may be helpful. So that's why a lot of people with pulmonary fibrosis will look into it. One more thing on the Pirfenidone that I should mention is a lot of people right now get really confused about this picture. And I think the confusing thing is, how should I get Pirfenidone if it's not available in the US? Can I get it through other means? And we'll look into getting it through other countries. It becomes really expensive and sometimes confusing as to whether the product is the real product or whether it's not the real product. And I've had a lot of people in that situation, and have not had a lot of people who ended up really happy with getting it from abroad because of the financial implications, and also finding that it was very confusing to get any sense of, well, is it definitely the right thing, and is it protecting my lungs, or what's going on? So people, of course, think about that and how can I get it, but oftentimes right now it's frustrating. I'll say, you know, patience is probably the best thing to exercise with it. Although some people have worked it out in a way that worked well. So emerging things, this is just one, and the reason I mention it is because we're getting ready to do this study at VCU, the site investigator. I had nothing to do with all the details of the study, but at VCU, there are many different hospitals that will participate. At VCU, I'll be the one overseeing the study. It's the, I guess, third one with pulmonary fibrosis I've been involved in, and I really backed into the first one. Another doctor had been doing it. He was heading into sort of a semi-retirement phase, and someone else just needed to do it. And I was new at VCU and just figured I should say yes to everything, so that's what I did for a long time. And that was one, and it took me a while to sort of figure out the importance of doing clinical research in pulmonary fibrosis, that this is how progress is going to be made, and just a strong belief that there should be something in the Central Virginia area that's offered with clinical research. So I've tried to keep it going. So there are several other medicines that are new and coming down. This is just one of them. And they all have that same idea of how are we going to attack that fibroblast? How do we get at the fibrosis? The antibody targets an enzyme that brings those fibroblasts into the lungs. This is a phase 2 study. About 500 people that have pulmonary fibrosis will be enrolled in hospitals all over. And one of the things I liked about it is that people can be on NAC or Pirfenidone or other things. So it had sort of friendly inclusion and exclusion criteria. At times we'll get frustrated if a clinical study, if there are 15 people that I meet that all seem to have pulmonary fibrosis and only 2 people get into the study, say, well, is this going to be applicable to the other 13 at the end or not? This one seems a little friendly. So lung transplant always comes up with pulmonary fibrosis, and it's a good thing to review because people with idiopathic pulmonary fibrosis sometimes do receive lung transplants. The general things that I would tell you, as someone who's not an expert in lung transplantation, but it's not always easy to qualify for a lung transplant. In general, a measure of weight called the BMI should be under 30. Age is a moving target. They used to say less than 65. Now there's some centers that have transplanted people at 78, but in general, some centers still stick to this pretty tightly. And in general, the rest of the body has to be in pretty good shape. So it's not always easy to qualify for a lung transplant. The results are not always as good as for other solid organs, but the results can be excellent, and certainly there's proof of that today here. So this is the ICU part of it. This is not necessarily with idiopathic pulmonary fibrosis, but I told you at the beginning that a lot of what I do is work in the ICU, and it's, I think, just my personality, because I do this with my wife. I tell her all this stuff, and so it's high on my radar.